So the case is about a 9-year-old boy with long QT syndrome type 1 that we saw recently in our institution. And he presented for the first time in 2017 elsewhere with an exercise-induced syncope. And this is what his ECG looked like at the time. Actually, this is a more recent ECG, but as you can see, the QTC is clearly prolonged. So here it's a little over 500 milliseconds heart rate for corrected QTC or QT. And as you can see, the T-wave morphology is also abnormal. It's a typical type 1 T-wave morphology with the broad-based T-waves. So he got genetic testing, and he turned out to carry this de novo variant that Professor Schwartz knows very well, because it's the South African A341V missense variant that his group reported in several of these circulation papers. So it's a South African founder mutation, causing a more severe phenotype usually than on the other types of long QT1. So this variant has a dominant negative effect, but as you can see here on the right side, the event rates are even higher than other dominant negative KCNQ1 variants. And also in a non-South African population, this variant is pretty malignant. So this boy was treated in 2017 with propranolol, 80 milligrams, and that's because in the Netherlands we don't have Nadolol, so we always use propranolol for these kind of patients. And 80 milligrams is around 2.5 milligrams per kilograms body weight per day. And he was allowed to participate in recreational sports like playing football on the streets and judo, but no competitive sports. And for around 6 years, there were no breakthrough events, and he was doing well. So the first questions I have for Peter, if you start a patient like this, when are you satisfied with the efficacy of propranolol? Meaning, obviously, you don't want to have any breakthrough events, but are there any other parameters that you use to assess the efficacy of propranolol, like the QTC, maybe at rest or during exertion, heart rate? What do you use to decide whether or not you're sufficiently satisfied with the effect, and if you think that the patient is sufficiently protected?
Chris, let me interrupt you for a second. I think it may be more interesting for all of us in the audience if I or anyone else or Veronica try to answer your questions as they come up. Because if you do it in 1 hour from now, everyone will have forgotten why you are asking the question. So should I begin to answer now, or would you prefer to carry on? What's your preference?
No, please answer now, and then because I only have a few slides for this case. So
okay, as to the first question, usually I am satisfied with the efficacy of propranolol as well as Nadolol. They are both very effective. Usually in a patient with the A341V, which is highly malignant, we would use at least 3 milligrams per kilogram body weight. Intolerance to propranolol, we see that very seldom. It's mostly depending on an excessively low heart rate. And if we see intolerance for that reason or any other, then we switch immediately to left cardiac sympathetic denervation without any hesitation. In terms of lifestyle recommendations, again, this specific variant is so malignant that usually we are a bit more restrictive than usual. I mean, I like to allow most of my patients to play, let's say, to practice sport in a pleasant way. With the A341V, they've got to be careful. I mean, it's very easy for them to develop problems. So I think one has to use also common sense. We don't want to generate psychological problems by forbidding a child or a teenager from playing, but care has to be exercised. And in terms of an electrical storm, well, you do whatever you can do with an electrical storm because it's an emergency. If the patient has not had already a sympathectomy, we would probably proceed with a pharmacological block of the left striatic ganglion. Besides that, there is not much that one can do, in my opinion. I don't know. Veronica, would you like to add something? You are muted, and therefore you've lost the right to answer. Chris, go on.
No, so maybe it's interesting for the audience also to ask you a few questions back. So you responded to the first question that it's mainly the target dose, right? You want to dose around 3 milligrams per kilogram body weight.
Well, usually we are happy with 2.5. It's between 2.5 and 3. It depends again on the specific characteristics of the mutations, the patient, and the only way to judge, quite frankly, you don't have a single parameter that is useful, is the clinical story that tells you if you've been effective or not. I mean, you have to treat the patient and wait. But generally speaking, between 2.5 and 3 milligrams per kilogram, that is usually very effective.
Yeah. Okay. So I think that's an important point, right? So in general, LongQT1, patients are extremely well protected with beta blockers, and the target dose is more important than the actual QTc at rest or what the exercise test looks like, right? Yeah. If you can achieve a good dose, then you can be pretty confident that the patient is well protected. And what about other KCNQ1 variants? If the patient is intolerant to propranolol, I have patients, who have severe nightmares, for example, and that being the reason not to continue propranolol. Would you, in less malignant KCNQ1 variants, switch to?
You are talking of uncommon cases. It happens. I mean, usually they have less problems with propranolol compared to nadolol, but sometimes we switch from one to another and we see what happens. I mean,
So you don't use any beta-1 selective beta blockers?
No.
Never. Okay.
No, never. No. Never, because they have no proven efficacy. There have been failures with them. And, this is a disease where a mistake may cost the life of a patient. Yeah. So I grew up doing a lot of experimental work, but I don't experiment on patients. Once we have a very safe treatment, we should stick to that.
Okay. And the last question, so the electrical storm. So what other steps can be made when a patient comes in? Like I was thinking esmolol, sedate the patient, lidocaine maybe. What would you do in a patient like this in the acute phase when the patient comes in with recurrence?
Well, you've got to manage it as you would manage any patient with an electrical storm. They're not different. As a matter of fact, it's not that common. I mean, I've seen you may see storms more with CPVT, but not so much with long QT syndrome. So you increase the dose of beta blockers. Again, if someone in the emergency room can infiltrate the left side ganglion with lidocaine, we would do that. But you've got to manage that patient as you would manage anyone else with an electrical storm until you take the patient out of the trouble.
Yeah. And do you think that lidocaine IV is helpful in those cases?
Under those conditions, you may try anything. Yeah. I mean, it's nothing to lose.
Okay, good.
Maybe, Prof, one last question about the specific sports to avoid, I think, in LongQT1.
Well, usually we prefer patients to not practice team sports. And the reason is that, for instance, if you play tennis and the opponent make a short ball, you may decide not to run and lose 15 points. But if you play soccer and your opponent runs away, you cannot just watch him. You've got to run because there is the pressure of the team. So the team pressure becomes a negative issue and increase your effort. So I would favor individual sports, individual games, where you're really on your own and you can decide how much you push yourself without the peer pressure.
And one last question, just for the Italian audience. You know that recently with the last coaches, for the first time we've got now the possibility to consider giving, a competitive possibility to long QT sports. What do you think about that?
Well, as a member of that task force, I cannot complain too much. I think it is a reasonable thing for patients who have, and that was the indication, a mutation who are taking beta blockers at full dose and who have a very mild phenotype. I mean, it's a 440, 450 milliseconds QT. So you have a mutation carrier with a very mild phenotype. Under those conditions, with a patient on beta blocker therapy, I would allow some degree of competition, but again, using common sense. Please go on, Chris.
Yes, I will. Yes, so recently this patient came to our institution after experiencing a breakthrough event. And this was exercise-induced. He was playing football with his friend on the street, but that was also on the day that he skipped one dose of propranolol. So he was admitted, and actually the ECG was the one I showed on the first slide. That was on propranolol, so the QTc at rest was a little over 500. And during exercise, there was no ventricular ectopy. Unfortunately, I don't have any ECGs of that test, but he reached a maximum heart rate of 130, and he had a pretty, as you would expect, a pretty long QTc during maximum exercise and also in the recovery phase. So yeah, he had an event, but it was also due to non-adherence. So what would you recommend, and when would you consider an ICD, right now, or do you think there are other options? And yeah, go ahead. Yeah.
Our policy is that if there is a first breakthrough event, and again, in this case, it was also associated with incomplete compliance, what we do is to go to left cardiac sympathetic denervation. We do that first because that is something that still allows us, if truly necessary, to add an ICD, but an ICD has a significant impact, especially in a child or a teenager, in terms of complications. We published in 2010 in Circulation a very large study on long QT syndrome patients with an ICD, and it was clear that within 5 years from the implant, 25% of them had major complications. So the ICD can be life-saving, is a fantastic thing to use sometime, but discretion should be used because it's not a free lunch. The patients pay a high price for that protection. So first, our definite preference is to go with a combination of beta blockers and left cardiac sympathetic denervation, which still leaves open the possibility of implanting an ICD if necessary. After having explained carefully to the patients and to their families that we are not providing 100% safe protection. We are increasing the protection as much as we can. It's not 100%, but there is a question in terms of quality of life. So it's also up to the patient and to the family. I think these situations require a shared decision between an expert clinician and the family and the patients.
Yeah, the third question, you actually already answered it before, but is your management of this patient with this malignant variant different from other long QT1 patients?
Well, yes, we always pay attention to the specific variants because they are not all the same. I mean, they're like Indians from different tribes. So you have to take that into account. And there is no doubt that the A341V is the most malignant one and the most likely to induce arrhythmias. This was actually my reason to come to work in South Africa in 1999, because as you mentioned, thank you for that, we have been following this incredible family of 500 individuals, all carrying the same A431 variant, and 80% of them, 80, are symptomatic, either with sudden death or syncope or cardiac arrest. So it's a highly malignant situation. And interestingly, you mentioned this de novo case in the Netherlands. I remember when I was discussing this family, South African family with Arthur Wilde, because the original affected person, this person came in South Africa in year 1690. His name was Peter Swart, S-W-A-R-T, which seems like destiny. But Arthur was uncertain on the origin, because even if that patient was Dutch, Arthur was unable in those days to find a patient with the A341B in the Netherlands. So now we have one, even if he said no. But yes, we have to be more careful with these patients.
Okay. Yeah, so fortunately we thought the same. So he recently got a sympathectomy, indeed, all uncomplicated. And we continued, or the pediatric cardiologist actually continued the propranolol. This is just a few months ago, so now he's doing well. And this is his ECG after the sympathectomy, 1 day after the sympathectomy, where you can actually see that the QTC is a little shorter. It's just below 500 milliseconds. So that's actually indeed the first question that I have already. How do you, is there a way, is the QTC important after the sympathectomy? Is it a good parameter to assess the efficacy of this?
Well, usually we wait 6 months to decide whether or not we think that there has been a reduced risk. That is largely based on the clinical situation and morphology and duration of the QT interval. Sometimes the QTC shortens immediately, sometimes it doesn't. But usually, if at 6 months post-surgery, QTC is below 500 milliseconds, that tends to be associated with good protection. As to your second question, if propranolol is still indicated, definitely yes, there is no reason to stop it. On the other hand, there are situations like patients with asthma, for instance, where they cannot tolerate beta blockers, and in those cases, we have just to rely on sympathectomy. The question about continuing or not continuing with beta blockers after sympathectomy has been raised a number of times. My usual answer is that unless there are significant side effects of the beta blockers, which is unusual, then I see no reason to reduce a good protective measure. I mean, sympathectomy is very effective, but again, it's not it doesn't solve all the problems. I mean, it's a reduction of risk, and after all, it prevents the release of norepinephrine on one side only, the left side, whereas beta blockers have a more complete effect on all cardiac cells. So I see no reason, no justification to interrupt or stop using beta blockers without a valid reason. And what is the next step? In a recurrent arrhythmic event, then we would implant an ICD, of course.
Okay, so I think the answer to the second question was important, right? So the sympathectomy is not a replacement of the beta blocker. It's just something that you add. I mean, sympathectomies are usually performed in high-risk patients, so they need double protection, if you will. And that sympathectomy plus the beta blocker they were on, right?
Yeah, one other important concept to remind is that I had shown long ago, I think it was 1976, that sympathectomy, left sympathectomy, raises the threshold for ventricular fibrillation, so it makes more difficult for a torsade point, for instance, to degenerate into VF. So patients may have a torsade point episode, which is less likely to degenerate into VF. So syncope may still occur without necessarily lead to sudden death. So that's another important concept to keep in mind.
And so in case of a recurrent event after the left cardiac sympathetic denervation, you said an ICD, but would you then also consider a right-sided sympathetic?
Yes, we did that for the first time 30 years ago, and that helped in eliminating that. That was before the ICDs. And with that bilateral sympathectomy, we did eliminate the events. We do it not very frequently. Sometimes we do it. I mean, it's I'm not sure how to describe it. It's really sometimes a gut feeling. It depends on what are the conditions associated with the event. If we feel that they are exercise related or related to increases in heart rate, then I think right sympathectomy becomes even more rational because, as you know, the sympathetic control of heart rate on the sinus node comes primarily from the right-sided sympathetic nerves. So by taking out also the right sympathetic nerves, you are significantly preventing rapid increases in heart rate. And that's also important in conjunction with beta blockers. So there are situations where we favor going to right sympathectomy first. It also depends on the age of the patient. I mean, if we are dealing with a young patient, we may favor denervation over an ICD. But again, it's sometimes it's an individual call based on also your feeling, your experience, and what you think is best for that patient.
Okay, thank you. Yeah, so those were my questions. Maybe we can now take the questions from the audience. Let me.
Okay, I see that there is a question. During neonatal period, symptomatic long QT and no other concerning arrhythmia, when should we start off beta blockers? Okay, that's an important question. Now, it has to be kept in mind that in the first week of life, the QT interval tends to be prolonged, and you may have spurious QT prolongations. On the other hand, if you see no prolongation in the first week of life, it's very unlikely that this will develop later on. We usually, in our screening program, decided long ago to assess the QT in infants in the third, fourth week of life, because at that point, the situation is rather stable. And if you have a QTc that is clearly prolonged, then you start beta blockers for the simple reason that you cannot take the risk of the infant dying of something that would be then labeled as sudden infant death syndrome when it's simply a death related to long QT syndrome. Meanwhile, of course, you do the genetic testing. That will take 8 to 10 weeks to get an answer. But our policy with a long QT in an asymptomatic infant, if we are sure that the QT is long, and even if there is no family history, I mean, if there is family history, clearly the diagnosis is very likely, but even in absence of clinical history, we would start beta blocker therapy, and then we reassess everything at the end of the first year of life. But meanwhile, the main issue is to provide protection for the infant. I see that there's another. Sorry?
What's the cutoff? So you say it's clearly prolonged. What would be your cutoff for QTc?
Oh, around 470 milliseconds.
Okay. So for example, if this boy would become a father one day, his future child would have a 50% chance of carrying the same variant. We would usually, I'm sure you will do the same in Italy, take blood from the umbilical cord, right, to test for the variants. That takes a few weeks. So in the meantime, if the baby has a QTc over 470, you would start a beta blocker while waiting for.
I would start the beta blockers, yes. I mean, I prefer to stay on the safe side with infants. I mean, there's no reason not to do it. And this should be done with the understanding that this decision may be changed as time progresses and one has a better evidence of the situation. Again, also with a fast heart rate as you have in newborns, the QT measurements is not well defined and certain, so there could be mistakes. So my recommendation is, if you think that the child has a truly prolonged QT, then you start using beta blockers, and then you reassess the situation as time goes on. I see that there is a question, is your advice of left sympathectomy as strong in other genotypes than LQT1? Absolutely, yes. 100% yes. We have a very similar answers independently of the genotypes. In the JACI-P article published a couple of years ago by Veronica Duzzi, we show that there is really no difference. The only potential difference is in de novo infants with LQT3. Mike Ackerman has reported a few failures, but again, there is so little to lose. Any role of atrial pacing, that's another question. We use it very seldom, very seldom. Mostly in some LQT2 patients, especially women, who tend to have very low heart rates, and sometimes they apparently benefit from raising their heart rate. And actually, what's your experience with that, Chris?
But yeah, so it's little, but I think if the this person relates it to this case, I think in LongQT1 there's no clear role, right? If anything, it would be in LongQT2. Yeah, so we sometimes, when we, for example, decide to implant an ICD, we go for a dual chamber to also be able to pace in the atrium at higher rates, also to prevent the pauses. So that's.
Veronica, would you like to add something?
Yeah, maybe I think depending on the situation, we actually proposed in our, flow chart for patients who still have recurrences or seems to not be responding well to beta blockers to consider pacing. I think, of course, it's hard not to implant an ICD in long QT patients, but still, if you really have the perception that arrhythmias, particularly long QT2, are really heart rate related, it might be a really good option, because at that point you just have one catheter. You don't have all the issues related and the potential side effects of the coil and of the ICD. So I think that might be, very, very selected cases, but rather than going to an ICD, sometimes just the combination of beta blockers, denervation, left denervation, and then pacing might be enough. And then you would only have one catheter, which is by far much better than having also the device, the defibrillator system within you, particularly if you're a child.
Okay, I see another interesting question, which is the following. How would you manage a neonate 2 months old with a positive KCNQ1 genetics and the normal QTc for 130 milliseconds? Would you start beta blockers? That's an interesting question and not an easy one. I can tell you what I would do. And when I say what I would do, I'm always aware of the fact that I can make a mistake. If I make a mistake, I want to make a mistake on the right side. Now, here we have an apparently normal QTc. And the first question, is that really normal? Was it measured correctly? What was the heart rate? Because if the heart rate is very fast, the measurement may not be correct. What we do have as a hard fact is that there is a variant on KCNQ1. So my first question will be, where is that variant? Because we know that there are variants in certain parts of the gene that carry a relatively small risk, others that are associated with a higher risk. And in any case, being in the period of life where sudden infant death syndrome can occur, I would prefer, if these were my grandchild, to protect the infant with beta blockers for a few months. Meanwhile, heart rate will progressively come down a little bit. We will see what happens. I would have more information perhaps on the genetics, but I would like to take the infant through the first 6-8 months of life with protection. And it may not be necessary. This does not mean that the child, if the child remains with a completely normal QTc, one may discuss the use of beta blockers, even though we should remember that even phenotype negative, genotype positive patients have a 4 times greater incidence of lethal cardiac events. So one should be careful. Let's never forget that this is a disease that can kill, and I would prefer to give a beta blocker without need than to see the parents crying because they've not given the beta blocker.
But this is, if I may add, this is clearly a difficult question, right? And controversial case, how you put it. I think
Chris,
in them, yeah.
If you agree, I think we should move now to Veronica's presentation, because I'm sure there will be a lot of other questions. Just one thing, there I see another question about having an automatic external defibrillator at home, and what are the advices for the parents? Okay, that's an important question, particularly for those subtypes of long QT syndrome that are associated with sudden death during sleep. And I mean LQT3 and also LQT2. So they should know what to do. Very importantly, they should learn a thumb version, because the recommendation of simply performing the traditional CPR does not work well with channelopathies and long QT syndrome. It's 10 times more effective to perform thumb version within 30-40 seconds, because in these cases, most of the hearts return in sinus rhythm and without any cerebral damage. So that's an important knowledge for the parents. If there is a suspicion of LQT3 or LQT2, I also suggest intercom in the rooms, because patients dying in the sleep often do not die silently. They make agonic sounds, sort of this kind of thing. And the reason is that it's a very different thing. If you develop VTAC and VF, if you're standing, then you fall on the ground and things happen quickly. However, if you start having a VTAC while you are in a horizontal position, blood pressure goes down very slowly, oxygen consumption comes, perfusion goes down, and then you have the agonic sounds due to lack of oxygen that are very important, because they may wake up a spouse or someone else sleeping in the same room. So they may be a signal that is alerting that the patient is close to die and may allow a prompt intervention. This is something that is often disregarded, but is extremely important, because many lives can be saved in that way. Okay, let's move to Veronica.
Okay. Can you see? Can you see the presentation? Can I go on?
Yeah,
Yes.
we can see. Speak up and go on.
Okay, thank you. Okay, so we are talking about a new child, Max, which is of course a fantasy name. He was born in October 2016 at term with a C-section in a very small Italian town with less than 5,000 inhabitants. He was doing really fine at birth. He had a completely negative cardiac family history, and he was almost immediately discharged due to the excellent clinical condition. And the 1-month neonatal ECG screening was planned, as per usual in some, but not all, Italian cities, since nowadays it's still not mandatory in Italy, as in the rest of the world, the neonatal ECG screening. So these are the results of the screening. So Max came back 1 month later, and the ECG, as you may see, was extremely pathological. So the mean heart rate was within the normal range for age, so 158. There were notch T waves in several leads, from V4 to V6, and in the peripheral leads. And these are the QTC measurements, so almost 500 in V2, and more than 500 millimeters in V2 and V5. So extremely prolonged QTC values associated with the pathological T wave characteristics. And by applying the well-known scores, we considered the modified 2011 criteria a point 4, Schwartz score of 4, that goes up to 4.5 when using the modified criteria proposed by the European Society of Cardiology, that, as you know, they would add a 0.5 to QTC above 480 in order to have enough points to do the genetic analysis. So based on that ECG, what we do have done? This is, of course, kind of a rhetorical questions. Please remember, based on also what Professor Schwartz previously told you, that we are outside the window where the QTc may be a little bit longer, so in the first weeks of life. So we generally wait for 1 month, so we can at least be sure to avoid or to reduce consistently the number of false positive. In that case, the ECG was clearly abnormal. So the second question is, would you refer the patient to a specialized center for, of course, the confirmation of the diagnosis, to perform the genetic analysis, and to start beta blocker? And what about the parents, of course? Would you assess the parents? And he also had a young older sister, despite the cardiac family history was negative. I don't know if Professor Schwartz, you want to say something?
No, I think you should go on, because the questions that you are asking seem more for the audience than for me. I think I can answer those questions, but let's go on.
So, of course, the patient was referred to a cardiologist, and he was seeing just 1 month later. So the ECG was completely unchanged. So the data were completely confirmed. So very prolonged QT with the pathological T-wave morphology. As expected, the cardiac ultrasound was completely normal. And therefore, at that point, the pediatrician, the cardiologist, pediatrician planned an hospitalization. This is something that we might also be discussing, because, as you know, in adults, we generally start beta blockers without planning an hospitalization. And honestly, it is what we also tend to do with infant. I mean, depends on the case, but for instance, in that case, with such good heart rate values, it might be considered safe. Also, of course, we have to perform an Holter ECG before and, of course, after and while during the titration of the drug, but it can be done safely also in an outpatient basis. But in that case, the child was managed by a pediatrician, and he felt more confident in admitting the patients. He was just admitted for actually a few days, just 3 days, and then they started with propranolol. They went up until 1.5 milligram per kilogram per day, and then he was discharged. Actually, in the next few days, the dose was lowered due to very rare, but happens, gastrointestinal intolerance. At the same time, the blood was obtained in order to, of course, perform the genetic examination. When the child was referred to another center to have the genetic examination, he was also switched from propranolol to nadolol once per day in order to favor mostly the compliance. So these are the results of the genetic analysis. At that time, remember, it was 2017. We didn't have such strong evidence that we have nowadays on calmodulin, and therefore the conventional panel of genes only included 5 genes, so KCNQ1, A2, SCNI5A, and E1 and E2 potassium gene that you know are mostly associated with drug-induced prolongation of the QTc. So the results of the genetic analysis were pretty straightforward. We found an C4 genetic variant, missense variant, in KCNH2 gene, and it was localized in a very well-known region for being associated with an increased arrhythmic risk, so the pore region. The location within the pore was very conserved. Other variant had been described at the time in the same region, but this specific variant had never been described at the time, and accordingly it was a C4, not a C5. In addition to that, the genetic analysis also reported about the presence of 2 heterozygous polymorphisms, one affecting KCNH1 and the other one affecting KCNH2. Both these polymorphisms have a minor allelic frequency that is, above 10%, meaning that they are pretty common in the general white population. And as you may see, the K970 had at the time estimated minor allelic frequency by the lab, of course, who performed the analysis, of almost 20%. So it's really pretty common. And it had already been described as being associated with an increased arrhythmic risk both within the long QT and outside in other settings, such as, for example, coronary artery disease. And of course, all the family members were screened, but just remember for the pathogenetic variant, likely pathogenetic, not for the polymorphism. And so based on that results, of course, the risk profile of the patient was enriched, and of course, we were able to estimate a much higher risk based on that results. And so we reassessed the patient when he was in the target dose of Nadolol, and these are the results. So as you may see, the heart rate was well controlled. Nonetheless, the QTC stayed very long, so above 500 milliseconds. So almost the same values as that we observed before starting beta blockers. The Holter ECG confirmed a good heart rate control with the drug. We also observed relatively frequent, actually not that much considering that it is a child, premature ventricular accomplices of benign morphology, so they were fascicular, and they were strictly heart rate related because they appeared only with heart rate 900 beats per minute. The QTC values were again very, very prolonged with a maximum calculated QTC of 530 milliseconds. This is an example, as you see, of the behavior of the PVC. So below the 900, you see there is bigemini. So you have, of course, one regular beat and then the PVC. And then the PVC were completely suppressed when heart rate went up, so above 900 beats per minute. So at this point, based on what all you know now, what you would have done? So we have a 1-year-old asymptomatic long-QT2 toddler who is harboring a de novo mutation in KCNA2, which is located in the core region of the gene, and is also harboring a polymorphism common but associated with an increased risk, specifically in long-QT2. The findings on beta blockers are still suggesting an increased risk because the QTC is above 500, and also there are, in this setting, PVCs. So what would you have done at that point? Just increase the Nadolol dose to 1.5 milligram per kilogram per day, considering that the heart rate was good, but still permissive to increase the dosage. You would have preferred to try mexiletine, and if so, how? Finally, you would have preferred to directly go to something invasive like left cardiac sympathetic denervation, or even an implantable ICD. Finally, you would have done nothing, so just check the patients during the follow-up. And then, Professor Schwartz, you want to say something?
No, go on.
Okay. So what we did was to increase the dose of the Nadolol because, as I told you, heart rate was still permissive, and this is what we found. So the heart rate went down for additional 5-10 beats per minute at rest. So there was an effect on heart rate, and therefore and supposed biological effect of increasing the dose. Nonetheless, the QTC, as you see, stayed extremely prolonged, well above 500 milliseconds. The Holter ECG confirmed the effect on the mean heart rate, and based on what I told you previously, since the PVC were mostly heart rate related, of course, heart rate went down and the burden of PVC increased a little bit. Again, the QTC was extremely prolonged, sometimes even above 550 milliseconds. There is, the last step of the increased risk. Actually, the good thing was that there weren't many, although there was, sinus heart arrhythmias, the maximum RR interval was not that bad. So, that was relatively a good thing, particularly knowing the fact that it was on high dose of Nadolol. So there didn't seem to be, dangerous bradycardia-related situation. So at that point, we suggested to shift from Nadolol once to Nadolol twice in order to provide a better protection, particularly in the first hours of the morning, also considering this is a long QT2 patients. And then, of course, we weren't satisfied just of that, and we also proposed to perform the mexiletine oral load test in order to assess the effect of the drug on the QTC. We used a conventional dose, which is around 5.5 milligram per kilogram. In the child, it was 72 milligram that were administered in one solution, so orally. And then we monitor the ECG at least 1 times every 15 minutes, and ECG was recorded and of course printed. So this is the baseline ECG that is absolutely equal to the previous one. So 537 milliseconds of QTC in D2. And an absolutely similar value was observed after 2 hours. So there wasn't an acute effect of mexiletine on the QTC length, and also, trust me, on the morphology, it was completely similar also in the precordial lead. So based on these results, mexiletine didn't seem to actually add something in the protection of the child, at least based on the QTC impact, and therefore he was left just on Nadolol. And the subsequent examinations of Nadolol were absolutely similar compared to the previous one. So the QTC, as expected, stayed above 500 milliseconds at rest and almost 550 at older ECG. There was an increase in the PVC burden, although, as you know, it might be extremely variable from one day to another, so that really doesn't mean a lot. So the two most important things, of course, were the extremely prolonged QTC values. And also, when looking at the T-wave morphology, as you may see, there were changes in the T-wave morphology that really, it is important to remember, did not represent a T-wave alternance, but they were mostly related to breathing and sometimes even to the length of the previous RR interval. And this is the minimum heart rate, so at night, around 2 in the night, and this is the maximum heart rate. So as you see, there are important T-wave abnormalities, both in resting condition and during effort while the child was playing. And this is another example. Here I show you all the leads, just to remind you how important changes were observed just as a result of changes in the RR interval. Here you may see changes in the T-wave, although once again, we are not speaking about T-wave alternance, which is absolutely another thing. These are changes in the T-wave strictly related to the length of the previous RR interval that you may see both during sinus arrhythmias, as in this case, and after a PVC, as in this case. So once again, to stress the severity of the morphology. So in this condition, what you have done? So first thing, he had a lot of PVC. You would have ever considered to perform, since they were all monomorphic and now infundibular, so no more fascicular, so we are not damaging the conduction system. Would you have considered an ablation rather than atrial pacings, since they were heart-related? So you would have been more worried just about the PVC, or you would have focused on the QT, and therefore on the need to shorten the QTC, therefore trying to administer, for instance, mexiletine in chronic, despite there was the lack of an effect in the acute setting, hoping to see something in the chronic, either on the QTC length or on the T-wave morphology, or once again, you would have jumped to something invasive, and if so, what? So left cardiosympathetic denervation rather than ICD, or something to just monitor. We will, of course, talk about that later. You know, the use of loop recorder isn't really codified in the setting of long QT. Sometimes, of course, it might help, particularly in peculiar situations like this one where there were also PVC. So we went on with the CSD, so with left cardiac sympathetic denervation. The boy at the time was 4 years old, so therefore it was small, but I mean, not that small, so we were able to perform the procedure in a completely safe way with thoracoscopic surgery, video-assisted thoracoscopic surgery. That means general anesthesia, of course, but also single lung ventilation. That, as you know, is the main issue when you are performing the procedure in such small children. As per usual, the sympathetic chain and ganglia from T1 to T4 were removed, and there were no complications at all. So we were expecting, of or at least we hoped, based on our large experience with LCSD and also based on what Chris previously showed you, to observe an effect on the code QTC, but unfortunately, in this specific case, we didn't. So the QTC stay longer, so well above 500 throughout all the 1 year after CSD. So as Professor Schwartz previously told you, we would expect at least until 6 months the possibility to see a shortening that we didn't see. So we decided to try with mexiletine despite the lack of the acute effect. As a matter of fact, the QTC values were completely unchanged even 6 months after the addition of mexiletine. So despite mexiletine and LCSD, in this very severe case, the QTC stay absolutely similar. Good thing was that Max had stayed asymptomatic, so of course no events had ever happened to him. Until something else happened. So in the next 2 days, in the next 2 years, there was an extremely variable PVC burden at wholesale ECG that went up to 47%, meaning that it was bigeminy for almost entire duration of the wholesale ECG, with the T-wave pathological morphology that I previously showed, that sometimes it was even more pronounced. So it was discussed a lot with our center and another pediatric center. There was a big discussion because the child was small, and as you know, when the child are really small, there is also an increased risk of pocket infection below 20 kilograms. We decided at the end to go for an implantable loop recorder, but probably wasn't such a good idea because it developed a pocket decubitus that was followed by the need of replacement of the device. And immediately after the replacement, there was a severe local, but still severe infection with a very high temperature, above 39 degrees. Initially not well responding to antibiotic, and in this setting, the child developed a malignant arrhythmias, although self-limiting, that was monitored by the loop recorder, and it was for a syncopal torsade de pointe. The boy actually had some more episodes during the first days of hospital admission while the temperature were going down thanks to the antibiotics. As you see, the potassium level were good, so it was not an hypokalemia favored condition. At this point, again, there was a big discussion, but it was decided to go to the implant of a dual chamber ICD. We were, reluctant at the beginning, but mostly due to the, documented ventricular episodes, the decision was made, to go on with the pacing system, of course, combined with a subcutaneous coil to be able to accomplish the fibrillation. Interesting thing is that, as you know, in adults, we don't perform the induction test any longer because we have very well referred values, but it is still very usual to do so in children. So they tried earlier, as soon as the child came in the P-lab, he went spontaneously into VF that was limiting, and then they tried again for 7 times to induce ventricular fibrillation, but they weren't able to do so, even with very aggressive attempts. And of course, we will discuss about that rated and about the potential and I would say impact of left cardiosympathetic denervation on the impossibility to induce VF. So at that point, the decision was made to switch from nadolol to propranolol in order to be able to go up with the dosages. And the actual pacing was set at 90 beats per minute. So far, no more ventricular arrhythmias had occurred, and there were no complications of the device. So 2 words about the procedure. We have already talked about, we did already talk about the denervation before. We recently reported the long-term results of the procedure with patients that were followed up until 50 years, so a very, very long follow-up. And this is our flow chart, so what we propose for the management of these patients. And as you may see, for those who are not protected by beta blockers, that by the way are a minority of long QT patients, in most of the cases, we are able to manage the situation with mexiletine and LCSD. It is really, really rare that we have to recur to ICD, and as a matter of fact, considering more than 1,000 long QTC patients followed by the group of Professor Schwartz, and for decades, so since the 70s, I would say, there were only 3% who received the ICD, but when looking at these 3%, so meaning almost 35 patients, approximately half of them were implanted before being referred to us. So they were mostly implanted in our center, meaning that there are less than 20 patients that in our group need an ICD. And why is that? Because, of course, we have very good results with blockers, with mexiletine, and with LCSD that does not only increases the ventricular fibrillation threshold, but may also have an important effect on the QTC. Of course, it doesn't happen in all patients, but still, as you may see here, we demonstrated that there is an effect. The effect is incremental, meaning that we can expect a QTC shortening for up to 6 months after the procedure. And the most important thing is that we see it in the setting when we need it the most. So we don't see it in the patients with a QTC below 500 before the procedure. We start to see it for those who have a QTC between 500 and 550. And the effect is even much more pronounced among those with QTC above 550 milliseconds. So in those who are really, really a very high risk of events. Actually, almost 1/3 of the patients with a QTC above 500 milliseconds are able to go down to below 500, so to really reduce the risk of events. Because as Professor Schwartz previously told you, the persistence of a QTC above 500 milliseconds 6 months after the procedure was associated in our case area with an increased risk of recurrences. Please notice that we didn't have even one single case of sudden cardiac death as a first event after denervation, because we always observe generally as a first event a self-limiting torsade point or polymorphic events, so preceding a more severe events, meaning that, of course, we have the time to do something else. So at the end, I've presented you the case, and so there are several questions that we might be willing to discuss, and I'm actually eager to listen about what Professor Schwartz will tell you about these topics. So, of course, we have already been discussing about the importance of neonatal ECG screening. Then we will, another point is how to deal with children, particularly with infant, so how to start beta blocker, whether during hospitalization or it is safe to start as an outpatient basis. Concerning genetic analysis, nowadays, which is the minimum recommended set of genes, that is different today as compared to 2017, although it was just 7 years ago. What we might be expecting, how the genetic analysis may affect, as we also see in the previous case of Chris, our clinical management of the patients, and how important it is to administer beta blockers on a double regimen base, so meaning 2 times per day as compared to once. I'm referring to NADOLR, and always referring to therapy. There are really several questions. First of all, about mexiletine. So can we really rely on the acute effect, or sometimes we can expect to have a chronic effect on the QTC and the morphology of the repolarization despite the lack of an acute effect? How we have to deal with PVC. So if there is a consistent number of PVC, since it might happen, because they are children, and we know that as much as 30% or 40% as compared to adults, sometimes they are not treated in children, while in this case, when should we worried in the setting of long QT? And then finally, when we should think about left cardiosympathetic denervation and what we can expect to observe after the procedure. Few words about the loop recorders. There are really, as I told you, not, codified procedure for long QT, but when we might think about that, and of course, is it safe when they are so small? And finally, when it is really, really necessary to implant an ICD, and is, I mean, it's really the only thing that we can do. And at that point, when we do implant in ICD, which one should we choosing? So thank you.
Okay, Veronica, thank you very much. Before we turn to the audience, let me just make a couple of comments. One is that you made a very interesting choice for your case, because usually one is tempted to present successes and to show that everything we do works perfectly well. And you have just presented a case when practically everything went wrong and almost nothing worked. And I find it very interesting. But actually, I think it's a clever thing because it's important to be fair. And it's important that we all recognize that even though we do always our very best, and this was clearly done in your case, it may happen that things don't work the way we would like. As a matter of fact, I think that your case represents a significant exception. It's not what we see in most cases, but it's important to realize that sometimes these things may happen. Now, beta blockers work in the majority of patients. Here, they didn't work, but we know that a number of patients may not be fully protected by beta blockers. Then you attempted mexiletine in an LQT2 patients. Now, we had shown and proposal that was already back in 1995 to use mexiletine for LQT3, which is very effective and is now part of the guidelines. We have just completed a study on almost 100 patients, LQT2, in whom we tried mexiletine. And it's interesting to know that in 2/3 of them, mexiletine works very well. And if you do the acute oral drug testing, this is highly predictive of how patients will respond during chronic treatment. We have actually observed shortening of repolarization also in the IPS cardiomyocytes from our patients, and also in an LQT2 rabbit model. So I think that we now have very convincing evidence that it is worth to try to shorten the QT in LQT patients if they have values exceeding 500. And the advantage of the acute oral drug test is that within 2 hours, you know if it works or if it doesn't. If it doesn't, you don't give it to the patient. If it works, you give it to the patient, and then you have 65% of probability of having success in shortening the QTc. When we do sympathectomy, the majority of patients stop having events. The majority does very well. The majority has a significant shortening in the QT interval. In your patient, we haven't seen this. So it's an important reminder that, again, not everything works all the time. And then one has to be prepared to act and to do other things. You use a loop recorder. I think that I've always been interested in the loop recorders whenever I'm uncertain about the symptoms reported by the patients. If it's unclear to me if they have an episode of vertigo or palpitations, what really is it? So the loop recorder is useful for that. And then in this case, when there was a first event, again, we don't know if it had been, what would have happened without the father's intervention, because it might have just been a long torsade de pointe without VF, but it might have ended up in VF. And at that point, it was absolutely correct to implant an ICD. So I think the management was completely correct. In terms of the ICD, one of the questions you ask is more or less how often should it be used? Well, last year with Mike Ackerman, we published a review article on the use of sympathectomy in channelopathies. And one of the things that we stated was that based on our experience on almost 3,000 long QT syndrome patients, it is our belief that both Mike and I share fully, is that very few long QT syndrome patients really need an ICD, and very few should be implanted. Sometimes they do, and this was one such case. So the fact that we use seldom the ICDs is because we believe that we can manage these patients with a better quality of life almost all the time, in probably more than 95% of cases, without an ICD. And that's an important thing for their quality of life. But sometimes an ICD is necessary and is going to be life-saving. So we have not, there's no bias against the ICD. We just consider it an extremely important tool in terms of managing the patient that should be used with care and in a careful way. What worries me when doctors rush into implanting an ICD without a good reason. Sometimes they do it also because it's the easiest way out. They recommend an ICD. No one could accuse them if something happens, so they've protected themselves. And if there are problems and negative complications and side effects, well, too bad, but it's the patient who's going to suffer. So I think that our job is a difficult one, because we have to take serious responsibilities. And of course, it's more difficult to discuss with a family of a child with a significant and high-risk long QT syndrome. Well, yeah, in other places, they have recommended an ICD. We would recommend it instead of doing A, B, C, but we cannot guarantee full protection. I mean, we still recommend that based on our experience, on the fact that we think that for your kid it is worth trying first with the other ways, but you've got to realize that we cannot promise 100% safety. So it's not an easy thing to do. It takes time. And I know very well that many colleagues don't have much time, so they need to get a decision quickly. But these cases should not be dealt quickly, because they deserve a lot of attention, and making mistakes is too easy. So I will stop here with my comment, and I think let's see what we have. I think we have some questions from the audience. Let me start from this one. It's interesting. Most of the people give their names. Someone asked the question in an anonymous way, so I don't know why. But so I said, what dose of beta blockers do you use in the beginning of the treatment, and how do you increase doses until full beta blockade? And well, what we learned over time is that if you start with a full dose, sometimes patients may have or feel some side effects, more fatigue, less concentration at school. And I remember very well, because I've started taking beta blockers for my blood pressure when I was 35, 40 years old. And I started with a full dose. And I remember that for the first few months when I was at a Congress, I was always slow in going to the microphone. So I was getting worried. Then all the symptoms disappeared, or I don't care anymore. I don't know which one is the correct answer. But what we do now, unless we are dealing with a patient who has already had an episode, we start with a very low dose, around 1 milligram per kilo for propranolol, or 25, 30 milligrams of nadolol, and we increase every couple of weeks. So we try to reach full dose within a month and a half. And in this way, we are able to prevent most of the complaints by the patients. Another question, still anonymous, is how low cardiac rate do you allow on beta blockers? Well, for an adult, I don't worry until nighttime heart rate goes to 35 beats per minute. I mean, that's my view. Someone else may not agree. Chris, what do you think about that?
Yeah, I don't worry either. So indeed, very low values. But in general,
okay, good.
I think the complaints go first before the very low values.
Exactly. And another question is, when do you recommend implantation of a loop recorder? Well, as I mentioned, I think a loop recorder is a bridge. It's really reflecting the fact that we are uncertain on what to do. I mean, that is the reality. Sometimes, one has to be honest, sometimes we are not sure about what to do. And one thing we do is sometimes use a loop recorder to see if we learn something more. One thing that some of us do, people like Arthur Wilde, myself, Sammy Viskin, Mike Ackerman, we write to each other and we describe our case and we say, I'm not sure about what to do. And I think this is an important message, because what bothers me a lot is to see that often cardiologists with minimal experience in front of a difficult case make decisions without really having the knowledge and without being as humble as say, I'm going to ask the opinion of someone who knows more than me. And again, Mike Ackerman and I mentioned this fact that some of us, probably with the largest experience in managing these patients in the world, sometimes we are uncertain and we have no hesitation in asking our colleagues an advice. What would you do? Veronica, who has been working with me for a long time, knows very well that when we see patients, it's not rare at all that I ask, what would you do? Because sometimes we need a second opinion. There is nothing wrong, never, for a physician to say, I don't know, I am not sure. That is never a wrong answer. Sometimes this means that the case is complex, there are more than one solution, and we don't want to make a mistake. And that is why, again, we write these messages by mail, usually within hours. Arthur Wilde or Mike Ackerman or the others answer. And that is a fantastic thing that happens in our community. Okay, any other question? Let me go down here. Veronica or Chris, is anything else that you would
there's one more question. There's one more question, but it's about the case specifically if the Torsades were induced by high or low heart rates. Maybe Veronica, can you comment?
No, it was I would say because he had fever, so it was not that slow. It was not a short, long, classical sequence.
It was not?
No.
Okay. Because that's usually what we see in type 2, right? Well,
yeah.
It's less often in type 1, but usually it's the classic Torsades in type 2.
Yeah.
The other question is how to correct the QT interval. So if we would suggest to use Friederichia formula above 100, a heart rate of 100 beats per minute?
No, I simply always use Bazette for a variety of reasons, which I'll explain. One is that we have shown and published in the European Heart Journal, I think it was 2018 or 2019, a study on 5,000 infants, where we show that even in infants with a rate that is fast, the Bazette correction works very well, contrary to what was held for a long time. And the advantage of the Bazette correction is that everyone is familiar with it. It maybe is far from perfect, is a gross measurement, we all agree with that, but physicians understand, or cardiologists should understand, that if you have a QTc consistently over 440, 450, you are entering in an abnormal area. That number is clear. With the Friederichia, most of the people, including me, are never sure exactly what that means in terms of the actual number. And I think it simply makes confusion. And again, one has to realize, however, that measuring the QT interval is a gross thing. It's easy to make a mistake. One has to be careful looking for the longest QT. There are questions that Chris knows very well about using or not using the tangent method. And I will be very delicate here because I'm talking also to the enemy camp, so to say. I am personally against using the tangent. The tangent is a fantastic shortcut because you get a measurement faster. The question is the measurement correct? My view is that especially with reductions in the potassium currents, IKS and IKR, there may be a prolongation of the action potential in the last part of the action potential, which means that if you take a tangent, you may miss a prolongation of the last part of the descending limb of the T wave, and you may underestimate the actual duration of the QT interval. Again, this is highly controversial, and I respect very much the views in Amsterdam. But again, I prefer not to use the tangent, to take a little bit more and to decide that the end of the T wave is where I count the end of repolarization. Again, I do understand that there may be different views, but Basset, in my opinion, should always be used because it's very effective in discriminating between normal and abnormal repolarization. Chris, you're welcome to make a comment.
Yeah, I won't comment on the last part, but I fully agree with Basset. I think it's also important to realize that a lot of the long QT syndrome literature that we use for risk stratification, for example, also used Basset's formula. All the important papers where different QTc cutoffs are provided with that one can use for risk stratification is also based on Basset usually. So another question is about, so when should we be worried about PVCs in long QT syndrome, specifically type 1 versus type 2 versus type 3?
Well, Veronica, why don't you answer that? That was your case.
Yeah, absolutely. I think it's most of all a matter on the impact, of course, on heart rate. So it depends on the amount of the pause that follows the PVC. So of course we should be worried if there is a potentially dangerous sequence. So a sequence that might lead to a short, long, short. This is of course the worst case scenario. So, for instance, there are like infundibular, like adrenergic trigger PVC that, of course, may happen in general population and also in long QT. And that I wouldn't be that worried about that because they are mostly heart rate related. Of course, with an increased heart rate. I think that particularly following children, we see them less because they are on beta blockers. So as we know, the treatment for that kinds of arrhythmias, PVC, is not all by itself. So we tend to see more those who are favored, like the one in our case, by low heart rate, because those favored by, adrenergic activity, they tend to be suppressed by the beta blocker. So in that case, I really, what we do is to look at the morphology of the T-way and on ventricular repolarization in the bit after the PVC. Actually, we do that also as a way, an incremental way to stratify the risk, because even if the QTc is not that prolonged, like conventional 490, but there are PVC and the bit after the PVC has a clear abnormalities that we cannot see in the other bits, like a second component. It is generally believed that the second component is the equivalent on the ECG of an early after depolarization. So really it means that the repolarization is unstable and there might be a condition of increased risk. So that's the setting where, I wouldn't say I would do that always, but maybe we might be considering the pacing if there is really an important pause after the PVC. Okay. Of course, I wouldn't do ablation.
Let me say something about the PVCs, because my reaction when I see PVCs in a patient defined as long QT syndrome patient is the patient really having long QT syndrome? Because actually it's pretty unusual. I very seldom see PVCs in long QT. So again, my first reaction is one of skepticism and to say, are we really talking of long QT syndrome? But of course, if you have a genetic confirmation, that's important. There is a question about, is a treatment goal to reach a QTc below 500, even if the patient has no event symptoms? I would say yes, because when you say the patient has no event symptom, you're really saying the patient has not yet had symptoms. The patient may have events anytime. Let's not forget that 2/3 of the sudden deaths in long QT syndrome occur as first event. 2/3 is a frightening number. So we don't have many chances to correct an error. So if the QTc is above 500, we should do our very best to bring it below 500. even if the patient is still without symptoms. Someone is asking about should we recommend a strong antipyretic prophylaxis in long QT syndrome? I honestly have never done it. I mean, we do that with Brugada, of course. In long QT, I think one uses common sense. If the child has fever, you lower his fever level. I mean, you do an antipyretic treatment, but I wouldn't do it in any specific way. Now, the case that Veronica has shown was one such case, but again, that case was really odd. Someone is asking, in case of high heart rate, notably in the recovery phase after an exercise test, do you still use Basette or do you prefer Hodges? Now, we Hodges, I don't like it at all. We have shown in that European Heart Journal that is the least valid of all the methods of correction. And again, I stick to all the Basette. Basette has limits, we know them, but we know what we are talking about. When we give a number with Basette, we know what it means. I mean, it's like the dollar. We know what is worth it. Do you always prescribe mexiletine in 3 doses? Yes, if we can, we do, because there is a relatively short life. Veronica, would you like to add something on the mexiletine? Or?
I totally agree with you. Of course, it's really a matter of compliance, and particularly it's difficult for the patient to accept, particularly if they are very young. So it often happens that it's really, as Professor Schwartz told you, a shared decision process, and we talk with the patients. And of course, particularly if he is or she is very young or throughout adolescence, it might be really an issue to take a drug 3 times per day. So if it's in primary prevention, we might discuss whether they would prefer to try left cardiac sympathetic denervation rather than mexiletine. Of course, mexiletine is a drug, it's not invasive, but it has been showed in the setting of mostly ventricular arrhythmias that really after 10 hours, you are not protected. And,
okay, we'll take one last question. Would you treat neonatal pediatric patients with a normal QTc but positive genetics for long QT? Now, I think that's an extremely important question. Personally, I have no doubt. If we are dealing with an infant or a pediatric patient, which means that we don't know the history. I mean, let me start from another point of view. If we see a 25-year-old man, a 30-year-old man, LQT1, asymptomatic, and for whatever reason he has a genetic screening, we find that he has a mutation for long QT syndrome, we may consider whether or not starting treatment, because LQT1 males over age 25 without symptoms of treatment have a very small probability of becoming symptomatic. But when you're dealing with an infant or a child, you have no idea on how things will develop. And now we have, yes, the QTc is normal, but you found a mutation that causes long QT syndrome. You decide to wait or to do nothing. Then when the child, the infant is 3 months old, is found dead in the crib. What do you do? And what do you think that the parents would do? I mean, it is cause for trouble, and it's not good medicine. If an infant has positive genetics, I think that the treatment with beta blockers is a must to start with. This does not mean that you will have to go on for life, but the mutation is there, so you have to figure out if it is a severe mutation, is not severe mutation, is associated with frequency of lethal events or not. And if the QTc remains normal at age 1 year or 1.5 year, then you may consider whether or not to continue. But I think it's a very dangerous approach to say, well, yeah, he has a mutation, but the QTc today is normal or yesterday was normal. Let's wait and do nothing. Because if something happens, it may be something irreversible. That, I think, is the main thing to remember with this disease. There is no room for errors. Now, I think we are entering in the last 5 minutes, and I've spoken a lot, perhaps too much. I think it's fair that Veronica and Chris and with a couple of minutes of their own points of view. But let me answer this last question because it's an important one. What about KCNE1 variant with long QT? Would you treat? Now, we're talking most often of the so-called D85 variant. If the QTC is within a normal range, we would not treat them. If there is a long QT, I would treat because there is a long QT, because I don't like that. Okay, Veronica and then Chris for the next couple of minutes each, making your conclusive statements, please. Messages.
I think that we have, almost covered the most important issue. Maybe I would say something just about the safety of beta blockers, because we are talking to pediatrician. We have told about the fact that it's important, very important, to start beta blockers even when you do have, a normal QTC, but a positive genetic analysis. And I really believe that it's absolutely safe, that beta blockers are safe. Of course, you have to tell the parents to be very careful, particularly if there is they are not feeling good, they are vomiting, and I think, that's really the only case I've seen. One case only of severe hypoglycemia because the child was not doing good. The parents were worried about the risk of arrhythmias and they do administer the beta blockers. But other than that, if they are properly instructed, I think that beta blockers are safe. So I think that's very important to be confident they don't have any other effect, because we are often asked about the development. They would suffer about something if they start to be treated with beta blockers where they are so young, but actually there are no data at all suggesting that. So
good point. Thank you very much, Veronica. Thank you very much, Veronica. Chris, your last comments and messages?
Yeah, just I think we discussed a lot of important issues. Maybe if I can add, we just submitted a paper. It's on CPVT, but I think there are a lot of similarities about how people think about taking their medicine and if they take the medicine. And we found that self-reported non-adherence of beta blockers was 15%. And most of these non-adherent patients indeed thought that the beta blockers had long-term effects on their body. So there's clearly a misconception, at least in some patients, that taking beta blockers lifelong is not a good thing, and that's why 15% admit not taking them. So there's an important role for us as well. Maybe one last question I wanted to ask you: do you think there's a role for spironolactone in long QT2? There's some people.
Yeah. We actually use it in some LQT2 patients who tend to have a very low potassium, because even if it has never been solved, this was one of the questions I had when I started working 45 years ago. There are definitely some patients, especially LQT2, who tend to lose potassium. That's very important. It's a very good question. Now, I think we have ended our time. I would just like to end by thanking very much Veronica and Chris for your presentation and the discussion. I would also like to thank the audience. All of you that we don't see you, and we miss seeing you. We would have loved to see your smiling faces or whatever. And we don't see you, but I would like to ask you something. If you have questions, if you have doubts in dealing with your patients, do not hesitate. Write to any one of the three of us. Write to Veronica, to Chris, to me. We will answer. Because this is something that we should do together as physicians. There should never be a long QT syndrome patient who risks his life because the doctor in charge doesn't ask the right questions. So we are here to answer any question you may have, and we wish to thank ERN and all the groups that have made possible this webinar. So thank you very much and have a nice evening.
Bye.
Thank you. Bye-bye.